So the woman is a month, the man is 3 months. So I say आदमी का cycle 3 महीने का होता है. Old thinking that a man can father a child till any age. So I follow a mnemonic called D-Clean. D-Clean is basically vitamin D, vitamin C, vitamin E, and then you have opening his pants to check for the varicocele is very important. So many times these men will say, sir, sperm count is improved, but we don't want to have sex with our partners. So treating the couple is not just the gamete, it is not just the eggs. The sperm also has its importance. I think that we should advise most men is, ma'am, thank you to the organizers, and it is a wonderful opportunity to talk about the males, because somewhere in the entire pregnancy, in the entire IVF, the entire focus is on the females and the men feel ignored. So the men are 50% contributors to the entire pregnancy outcomes, and it is time to understand that a lot of IVF failures and a lot of times it is actually the male factor which is involved. Thank you to my fellow colleagues who have here in the panel, and I think they'll be able to also, they are actually facing the same problem that we face, that the man is the last person to be treated. So the women keep on getting cycles and cycles, and the male is just a receptacle. He's limited to the semen analysis. So today we will try to figure out 3 clinical scenarios where advances are proving that before we proceed even for an IVF, the evaluation and the treatment of the male is very important. So optimizing the male factor, evidence-based updates for IVF, and I have tried to take 3 common scenarios, and just I'm not going to make it a very technical, because as gynecologists here, I don't think that you are very focused on the male factor, but the male factor also requires an important evaluation and treatment. So I'm Dr. Vijayant, I'm an MCH from PGI Chandigarh, I'm an MS from Maulana Azad. I have my own center in New Delhi where we are only managing male infertility and male impotency. So our work is completely on andrology, which is a sub part of the urology department. So treating the couple is not just the gamete, and not just one gamete. It is not just the eggs. The sperm also has its importance. And now the first scenario that we'll talk about is the normal semen analysis. So many times you will find men who are coming to you for unexplained infertility, where the wife has undergone 2 or 3 IVF cycles. They are having recurrent miscarriages, recurrent failures. So it is now a study which shows that 15% of infertile men will actually have a completely normal classical semen analysis under a microscope, right? So in these men, you'll find that the quantity is okay, the motility is okay, and but they are giving recurrent negatives with pregnancy or with IVF. So in these cases, the test that is now recommended and which needs to be done is a DNA fragmentation index or a sperm DNA fragmentation, which we still see very few gynecologists, even urologists, kind of prescribing, because the test is expensive and many of them don't even know about this test. Now the standard morphology that we do under with the microscope or with even the computer assisted semen analysis, like for example we have the lens hook. I think this should be able to tell you about DNA fragmentation. So these are advances in semen analysis, but these morphological tests don't look at the DNA. They don't look at the man's DNA. It is an old thinking that a man can father a child till any age, but after a particular age, even the man's sperms start showing DNA fragmentation, start showing large amounts of DNA abnormality, and because of this, a lot of times the embryo quality, the fertilization rates, even early miscarriages are very commonly because of this. So a DNA fragmentation test needs to be ordered. There are 2 tests that today we can order. One is the tunnel assay. The tunnel assay is basically done in labs like you need to outsource this, but tunnel assay is not done in small labs. A tunnel assay basically marks or labels the DNA fragmentation or DNA breakage sites, which can be tested under fluorescence, and this has the best predictive value for DNA fragmentation. But another easier test which is now coming is the halo test, in which the semen can be marked and can be analyzed in a regular pathology lab. So like for example, these AI-based new semen machines as well as normal semen analysis labs around your area can also be upgraded to do the halo test, and on basis of that give you a report which says that how much DNA fragmentation is the man carrying. Now the thing is, getting a test is one thing, but what do we do if we get the test and we find that the man is suffering from high DNA fragmentation? So now first thing is, when do we order this test? So one is unexplained infertility. So all men in your practice with negative standard workup. So if you're having couples coming in which the wife has been worked up and the man is again the sperm count is coming normal, but it's been 2 years, 3 years, they're not conceiving, they have had had 2-3 IVFs, not conceiving. So in all these men, DNA fragmentation should be ordered. These are GAF 25 guidelines, which is a global andrology forum. This is actually andrologists from across 35 countries which came together and gave these guidelines. Then second is recurrent pregnancy losses. Again, the semen, the DNA fragmentation needs to be tested. Then very important, clinical varicoceles. Now, varicocele is a very common cause of male infertility. It has been known for the past 40 years that varicocele repairs induce natural pregnancies, varicocele repairs improve your IVF cycles, but still, I still see men go for IVF cycles without their varicoceles being even checked or managed. So as a gynecologist, it's a request that every man with unexplained infertility should get a basic andrology workup in which basic semen test, basic hormonal parameters, and opening his pants to check for the varicocele is very important. I still find in my practice patients coming with grade 4, grade 3 varicoceles not even, analyzed or treated, and these men when go for an IVF cycle or go for a assisted reproduction will end up with poorer results as compared to and most of my colleagues in Rohtak and most urologists nowadays who are passing out are very well trained in managing varicoceles and treating them. And then we have the ART failure. So this is when you do the SDF. And how do we manage? Now, for example, you have a man in a couple in your clinic in which you have diagnosed that their DNA fragmentation is high. And now as a gynecologist, what we can do is the first thing that we should advise most men is obviously lifestyle changes. So weight loss, smoking cessation, removal of alcohol, improving the dietary practices, adding exercise. Now there are studies which say that even 30 minutes of yoga every day reduces your semen stress. So that is something that you should recommend. Second is medical treatment. So a lot of antioxidants and a lot of micronutrients can be given to improve the DNA fragmentation. But one more thing I see very commonly, one mistake, not a mistake actually, is most gynecologists write it for a month. So the woman is a month, the man is 3 months. So I say आदमी का cycle 3 महीने का होता है, ठीक है? तो man goes through 4 cycles a year. So if you start an antioxidant regime today, you will start seeing results after 90 days because the sperm which is going to be produced today will be ejaculated after 90 days. So if you have to start a man on any antioxidant regimen, we have to give him at least for 3 months. And before 3 months, we cannot. So many times 15 days of Maxosa L or 30 days of Nano-Leo total is actually not going to do anything because after 30 days, he's still ejaculating the sperms from the past. So the sperms actually tell you the picture of 3 months in the past, not what we are doing today, right? And so antioxidants, the most commonly ones that I see is lycopene, L-carnitine, CoQ10. Yes, very good. But the real antioxidants is vitamin D. So we have a lot of vitamin D deficiencies. So vitamin D, you should try to supplement. Vitamin C, again, a very strong antioxidant, which we should give. So I follow a mnemonic called D-Clean. D-Clean is basically vitamin D, vitamin C, vitamin E, and then you have L-carnitine, CoQ10. And so if you give this for at least 3 months to 4 months, you should see a very good improvement in the sperm parameters as well as in the DNA fragmentation report. Apart from this, now we have IV glutathione, very commonly used by our dermatology colleagues, but that also has a good response given twice weekly. I have seen that in our practice also. So we use that for patients with varicocele who don't want surgery right now, who are already being worked up for IVF cycle. So we ask ma'am sometimes, or we even ask the gynecologist, can we postpone the IVF cycle to maybe 4 months? Today I learned something new from sir that I can next time ask the ma'am to, put this lady on PE pause and freeze the eggs. Let me manage the sperm for 4 months and then let the man come back and then use those eggs. So I think this is again a wonderful thing I learned today, that I can ask the lady that you take less injections, go freeze your eggs, let me manage your husband for 4 months, and we'll send him back to the gynecologist after 4 months because many times I feel that the IVF centers kind of hurry up because they don't want to lose the patient. So if you can just freeze the eggs and let the man recover for 4-5 months, you'll get a better result in terms of pregnancy. Then the third thing that we can do is a varicocele repair, right? So every man who has a varicocele, subclinical, no, but clinical varicoceles, grade 2, grade 3, grade 4. And if he is below 30 years, if the wife is still young and he is showing signs of sperm distress, these men should undergo a varicocele repair, should be given 6 months to improve their counts and parameters before assessing or using them for ART. Unless the man is 35 plus, the couple is 35 plus, the woman is already now with poor ovarian reserve, they don't have much time. And in those cases, we can then with, prior consent and information, we can leave the varicocele aside and go ahead. But ideally, a varicocele repair should be indicated in these cases. And the one thing that is very good with the IVF centers is that if you are finding the ejaculated sperms to chronically show SDF, no improvement, then a TISA is a better way to get the sperms from the testis inside than to go for a ejaculated sample. In this, there is one update that I'm sharing, that when you have a man with a high SDF and you are asking him to come and give sperms for his IVF or an IUI, it's better to ask them for a short abstinence. It's better to you call them after 12 hours because fresh sperms kind of, give you better quality results as compared to the standard practice, 3 दिन का परहेज करना है, तो 3 days is not there for SDF patients. Then one clinical update that I want to add here is that nowadays we are seeing a lot of men who are overweight and who are having poor sperm parameters, who have high SDF, who have low testosterone, and these men are also being recommended for IVF, and they are giving poor results. So in these men where the E2, the estradiol T2E2 ratio is very low, where the E2 levels are very high, in these men letrozole is showing a lot of promise. So letrozole is again not only for women, letrozole is a very effective treatment for men. And if you have an obese patient who is above the BMI guidelines, 2 things you can do for them is, one, put them on lifestyle modification, ask them to lose some weight and come back. Start letrozole for them, it starts showing immediate improvement, but letrozole not blind, letrozole with T2E2 monitoring, and Mounjaro. Your Mounjaro also is showing excellent results in these men. So for men, we have treatment. So men is not only ICSI and IVF. For men, optimization has we have a lot of scope for you guys to refer patients to us. We can give you better results in terms of your, because end of the day, a failed IVF cycle is a very lot of distress for the doctor also. कैसे explain करें? But अगर we are able to, we have made a genuine effort to try to improve our, so I see that gynecologists are making a lot of effort towards the female, उनको optimize करने के लिए, but male partner को optimize भी बहुत जरूरी है. And clomiphene, letrozole again. Now clomiphene again, I see many gynecologists are comfortable prescribing clomiphene, but clomiphene is not a very effective drug for overweight men because clomiphene increases estrogen, and many of these men will come back with gynecomastia, with nipple tenderness, and high estrogen is a libido killer. So many times these men will say, sir, sperm count is improved, but we don't want to have sex with our partners because their E2 has gone through the roof. So when you do their E2 levels is 100, 110. So do not give clomiphene to overweight men. Put them on letrozole. Their E2 will be balanced. Their sexual drive will be sustained. They will continue to have intercourse with their partners, and you'll also find a benefit in their sperm count. Then this is one protocol in which if you are finding that these men have also low testosterone, we can add HCG. So an HCG with letrozole is called the power protocol. It's a name I give, and we find that it increases our sperm retrieval rate on microTSA up to 20%. So these are now stimulated microTSAs. So microTSA is not supposed to be non-stimulated. So if you are having a man go for a microTSA who has showing signs of non-obstructive azoospermia, who is having displaced hormones, so instead of taking the man directly onto a microTSA, it's better to optimize, improve his hormone counts, and then do the microTSA. The results are better, the sperm retrieval rates are better, and theoretically, because we don't have so much patience, we do like 4 or 5 microTSAs in a month. But if you look at the overall centers data, the results are better. And then anastrozole is a cheaper letrozole, so anastrozole can be used. The only indication where you use anastrozole is that if the patient comes back with joint pains. So joint pain is a very common complaint to letrozole users. So in those cases, we can shift them to anastrozole. Otherwise, letrozole is very well tolerated. Now, these are 3 places where we will not use letrozole. One, if the man is thin. Right? So in thin-built men where E2 is already low, we will not use letrozole. So E2 levels are very important. If we suppress the estradiol levels too low in the man, even that again affects the libido. And in those cases where the E2 levels are low and where the man is thin, there clomiphene is actually a better choice. And in clomiphene also now, N-clomiphene is better than clomiphene because clomiphene you need to cycle, and clomiphene you can give continuously for 3 months to the man in question. And then where we come in, the andrologists and the microsurgeons and my urology colleagues is varicocele, right? So varicocele is now, there is no question about it that varicocele repair improves infertility. Now the debate is no longer there. The debate is now, how do you manage the varicocele? So there's no longer question that should we manage the varicocele. Yes, the varicocele has to be managed. And 40% of men after varicocele repairs will be able to conceive naturally, but we yet do not know which of those men. So we are collecting data, and slowly we are getting nomograms with which we can predict better that which man, based on age, testicular size, hormone levels, grade of varicocele, what kind of repair was done. We can predict the reversal of getting the sperms back. So now one is ICSI fixes everything. So why operate? Yes. So we have this tendency, ICSI hai, sperm dhoond lenge. But even if you have a very good sperm on ICSI, which is again a morphological criteria, these sperms will carry acrosome defects. These sperms will carry DNA defects. These sperms will not be able to give you good embryos. So ICSI does not fix everything. ICSI, so it's like basically the quality of the material decides how good the food tastes, right? So if you are going to use a bad quality sperm, you're going to get a bad quality embryo. So that needs to be understood. And then varicocele causes DNA damage that ICSI cannot fix. So we have to manage with whatever steps I told you. And then surgical repair. So this is now guidelines now that surgical repair of clinical varicoceles prior to ART significantly improves outcomes. This is from ASRM. This is from EAU. ITU. This is now almost in every guideline now. And again, now this is now a new indication that consider repair even in non-obstructive azoospermia to improve sperm retrieval rates doing micro-TSA. So even if a patient is going to micro-TSA, it's better to repair it. 6 months, we'll get better results. Now this is a small decision matrix. Now if the female is above 38, already low ovarian reserve, there's no time. So you do not repair, go straight to IVF. If they are willing to store their eggs, give the man some time, yes. But usually varicocele repair time also depends upon unique circumstances in India. So what we get our regular patients is newly married, varicocele detected. Now varicocele repair either ideally 1 year before marriage. So what we see is that if men come, they're about to get married and we can do it, it's better because after varicocele repair, we usually ask them for abstinence for 3 months, right? So on a newly married couple doing a repair will distress their married life, right? So we tell them, okay, you do the precautions, wear a support, take your antioxidants, continue, maybe you get a natural tendency and then you do the repair versus somebody who's been trying for 5 years, the couple is still young and then again we can, repair it and give them the 6 months of abstinence to improve. Now there is a clear winner that microsurgery is the best. Open surgery and laparoscopic surgery, Palamos, because in laparoscopic surgery, you are actually clipping the artery and the vein both. So laparoscopic surgery is based on this principle that testicular artery has no role. So it basically says that testicular artery or somatic artery can be clipped and the basal artery will carry the blood supply. It is not true. Any blood supply that we can preserve is the best. So when we do microsurgery, we preserve all blood supply. We preserve all the arterial flow. So microsurgery is better in terms of sperm retrieval improvement, fertility potential, testosterone improvement, testicular atrophy, everything, right? So microsurgery is the clear winner. There is no doubts about it. Now, the only question that's coming in now is embolization, right? So you got a lot of radiology colleagues who will come to you and talk about embolization versus microsurgery. They say embolization is quick, OPD basis, but embolization has some problems. So embolization is retrograde sclerotherapy. So you are putting gel foam and you're putting coils inside the testis. So before microsurgery came, the urologists were doing sclerotherapy. So before microsurgery became an in thing, why did microsurgery come in the first place? Because in 80s and 90s, the treatment for varicocele was sclerotherapy, like hemorrhoids. So urologists used to inject STS and foam in the testicular vessels to block them. The problem was that these chemicals cause intense inflammation and they cause intense endothelitis and intense otitis. That is why these went away. Now we have come back to the same story with radiology, interventional radiology saying that no, it's okay. We can just put a catheter through the femoral and put the dye back into, but we are putting chemical dyes near a testis, right? So we don't have to do embolization. If you have a trained microsurgeon, which most of your urology colleagues are, you should refer your patients for microsurgery because microsurgery will definitely give you a result which is phenomenal. So we have seen men naturally conceive. So I'm compiling my own data, but now there is almost a 35% chance of natural conception, but when? But the only thing is, can the couple wait for a year? The problem with varicocele repairs is that the couples don't want to wait. They're like, sir, surgery कर दिया, अब अगले महीने बच्चा हो जाएगा तो नहीं होने वाला है. So what we tell them is you do parallel, right? You go for an IVF and at the same time also repair your varicocele. So we have been trying to fix up with ma'am that if we can do the TESA and the varicocele repairs together, right? So and in the same anesthesia we can do both. So you can get one result now and then the man can improve for the future. And then so this is my main message that for every man unexplained infertility or poor count, get a DFI, DNA fragmentation index. On the basis of DFI, try to optimize him. The most common cause of DFI in Indian population right now is varicocele and overweight patients with poor lifestyles. Try to see if you can manage them, or letrozole is a good drug. And if you have varicocele in front of you, instead of IVF, refer them to a urologist for a microsurgery. The results in terms of your success rate, results in terms of natural conception, results in terms of sperm quality improvement are exciting, are good. So successful IVF need 2 healthy gametes. Thank you for your attention. Thank you.